So if you want to proceed his talk, you can start right now. It's up to you.
Imaging MRI cardiologists, we will come across both those populations. So if we think about pediatric pulmonary hypertension, it's a bit of a problem, but most of the patients have transient pulmonary hypertension in our pediatric population. Oh, they have repairable cardiac shunts, but CHD-associated PH is still got a reasonably high prevalence, which is so it's an important issue. When you think about the causes, for those of us in routine clinical practice, we know there's pre-capillary and post-capillary issues, and that includes intracardiac shunts and sometimes structural lesions in patients with CHD. And then you have the post-capillary bits where you have to think about structural lesions like pulmonary vein stenosis, and then what happens at the valve and ventricular level. And you can see this is not just anatomical, but also physiological parameters that we need to assess. And so when we do this, we need the CMR to confirm the diagnosis, assess the cause, stratify the severity, and also look at the effects, which also includes response to treatment. And that's really important because you're looking at things like whether or not someone is going to be responsive to pulmonary vasodilator treatment. Rather than empirical therapy, you tend to want to use a measured response to see if the drug is suitable for that patient. And so the role of imaging actually is mainly based on echocardiography. Separately with CMR, you have things which are really just limited to indices of ventricular function and size. So it's really an end organ effect that we're looking at here. And of course, for diagnostic purposes, we're talking about things like invasive pressures. So what we really want to do, apart from this rather what I would consider late stage of disease, we need to think about earlier stages of disease, particularly in children. And that's where I'd like to show you that measuring things like pulmonary vascular resistance through a hybrid combined MR and X-ray technique is going to be very meaningful to your patients. So if you take this example of a 5-year-old child who presents late with a VSD and a PDA, saturations are a little bit borderline. The breath is at rest, there's no hepatomegaly, and there's a loud second heart sound. So you know the pulmonary artery pressures are high. The left heart's a little bit dilated. There's a left to right shunt on echocardiography. And if you look at the flow across the pulmonary artery, you can see that the isovolemic acceleration time is just a little bit high. So in that case, you could think, well, it looks like a high pulmonary blood flow situation. And if you really want to work out the resistance, it's the change in pressure over flow. And we know that pressure is proportionate to flow. And so if you have a high flow situation, you have a high pressure situation. So a plain chest X-ray will show you that the heart is dilated. Here you can see the left atrium is dilated. So you have high left heart volumes. And because you have left heart enlargement, the inference is that your QP is still high. And actually, if you wanted to measure a true QPQS for the more borderline patient, this is what you do. You actually need your invasive saturations, and from your invasive saturations, you can work out what the QPQS is. But obviously, there's a very good way of doing this non-invasively, as we all know. By phase contrast CMR, you can directly measure the pulmonary blood flow and systemic blood flow, and very elegantly do a QPTQS in this patient group. And we know from, I mean, it's incredible, right? It's almost 25 years ago that Andrew Powell and the group in Boston did this. And you can see that there's very good correlation between invasive and non-invasive means of assessing QPQS with a tolerance of about 1.2. So it's a good test and we use it all the time. And if you then do it for patients who have more significant shunt lesions, it still holds true if you do your QPQS bioximetry versus MR, and this is work done by Philip Beerbaum a year later. And again, it supports the use of CMR in this way, and that's what we do all the time. We looked at a cohort of our own patients who had invasive cardiac MR with PVR studies, and there's a really nice cutoff of about 2.75, in which case you can be reasonably confident that the patients have a low PVR, which is suitable for biventricular repair. So if you look at recommendations for shunts, you know, the different recommendations you can look at. But really, if you've got a high shunt, you can have a repair. Of course, by MR, you can see that there are multiple things that you can do with CMR, and you do your ventricular volumetrics, you look at flow, you can assess scar, you can look at flow dynamics, and also you can do tissue characterization, like we've mentioned before. And things like 4D flow give you some really useful insight, which I will show you. So this is a patient with elevated right heart pressures on echocardiography. And you can see that there is a mechanical reason for that. There's distal branch pulmonary artery stenosis, as you can see in this volume rendered contrast enhanced angiogram to your left, and the black blood imaging to your right, which shows you the subsegmental distal branch pulmonary artery stenosis. You can also get pulmonary vein stenosis, and again, this is the role of CMR with contrast enhanced angiography, where you can see the pulmonary vein stenosis. So this is a form of postcapillary structural pulmonary hypertension. Of course, there are more up-to-date non-contrast techniques, and this is using an MTC boost sequence that was developed by Claudia Prieto and René Bottner and applied in our cohort of patients with congenital heart disease at King's College London, with really excellent results where you can see isotropic 3D whole heart, bright blood and white blood imaging to show the anatomy. Of course, in patients who have the Schoen type complex, where you can have a constellation of left heart issues, here you can see there's endocardial fibroelastosis in the bottom right-hand corner with that circular lesion of late gadolinium enhancement, explaining the elevation in the left ventricular end diastolic pressure, elevated left atrial pressure, and thereby giving you post-capillary elevation in pulmonary artery pressures. Of course, you can also look at it not just in pediatrics with congenital heart disease, but with adults here, you can very nicely see pictorially the dilated right atrium, right ventricle, main pulmonary artery. But of course, if you give intravenous contrast, in this patient here with thromboembolic lesions, you can see the areas of loss of perfusion in most of the lung, apart from that right upper lobe segment, explaining the elevation in PVR. So the need for catheterization is clear because this is part of confirming the diagnosis of pulmonary hypertension. So you need to stick a catheter in. So you've got the change in pressure, which you need to get, which is mean pulmonary artery pressure minus left atrial pressure. And so when you're calculating the PVR, the QP is usually done in the cath lab. And in that situation, you have to estimate what the QP is based on the estimation of VO2. And so these measurements are multiple, they introduce error, and they also make assumptions about oxygen consumption in different patient groups. And you can see here there are different formulae, which I won't dwell on, but effectively they don't really work very well, they're unreliable. And if you make a comparison with the same data in different groups, you get wildly different results. And in the same way, there is a huge clinical impact. This is data from the team in Starlight at the Starship Hospital in New Zealand, again from a long time ago, but old data is still good data because here you can see on the right-hand side an underestimation of the true pulmonary vascular resistance in patients just from using the wrong tables, which would incorrectly place that patient as being suitable for a Fontan completion where they would originally not be. Therefore, you are saving them from the wrong operation. So this is what we did. This is our old lab. You can see a C-arm in the front and MRI scanner in the back, and you can get automatically put your catheters in under X-ray guidance, slide them into the MRI scanner. You've got the pressures there on the right-hand side, and you can also measure flow. So pressure over flow, you get resistance. This is our new up-to-date lab. You can see the biplane C-arm with interconnecting doors and our MR scanner, so you can move from one into the other very nicely to allow you to do that. Again, with pressure and flow, you can actually start to get things like resistance. You can use things like image overlay as well, which from the MR lab. And again, pressure and flow allows you to look at this and characterize the whole heart. So what I'll show you in the next series of images is how work done, again, historically, shows that PVR estimation in this way is much more accurate than the FIC approach, both at baseline and also when you move in with nitric and 100% oxygen. So, you do get these patients with, for example, this patient has Fontan, came to us with protein-losing enteropathy, and if you did the basic catheter, you will see that the pressures, the mean pressures here are not particularly high. Your transpulmonary gradient is only 8, which you think is not too bad, a little bit borderline. But the moment you plug this in and measure flow by CMR, the PVR here was 4.3 wood unit with some reversibility. And actually what we did for this patient, because the patient was really in a lot of trouble, we opened up the fenestration here with a stent to relieve the pressures in the fontan, because we knew the resistance was high and the patient's PLE disappeared. So that was really very helpful. We can do this without X-ray, of course, and this has been going on a long time, and a lot of labs are using this in a clinical setting. You can see there's a very dark round circle there with the CO2 filled balloon, which allows you to put a balloon wedge catheter either through the SBC IVC, depending which your approach is, and with this negative contrast visualization, guide your catheter placement into the pulmonary artery. You can also use positive contrast visualization by using a balloon filled with gadolinium, which is diluted, and apply a saturation pulse. Here you can see you have to choose between a bright blood and a dark blood images and switch between the two, and that was actually a bit of a problem. But what we then started to do is show you what we introduced, which was a partial saturation pulse. This is a patient with fontan, and you can see the NPR view here as I guide the catheter. That's my hand there in the bottom left. Push the catheter up, and you can see it going into the left pulmonary artery very nicely. You can also use it for things like dynamic fenestration occlusion, and there's a nice series of that described by Tariq Hussein's group in UT Southwestern in Dallas as a cohort of patients. They've also done things like improve the visualization techniques. Of course, it depends what kind of scanner you have and what kind of platform you have, but you can see here you're starting to show where the balloon is a bit more readily with a sort of red enhanced image here, and it increases the balloon visualization time. So what we're saying here, if you look at the clinical utility, the guidelines are now telling us we should be using this because it gives you enhanced diagnostic data, and hybrid measurements provide a more accurate and comprehensive hemodynamic assessment. So it's coming into the guidelines already, and that's actually really nice to see. You can apply this in clinical practice in patients without structural heart disease. This is Dan Knight's team in the Royal Free, and they invite lots of labs from around the world to come and look at what they do. But effectively, in under an hour, if you put the catheter into the right internal jugular and float it into the pulmonary artery, you can actually, without anesthesia, get a whole lot of patients done for accurate PVR assessment. In children, septal curvature has also been used as a non-invasive technique to actually try and characterize your patients a little better. And you can see here that patients with PH versus those with controls have different septal curvature, which is rather an intuitive point. But the serial assessment of this shows you that your right ventricular ejection fraction and stroke volume was strongly predictive of survival in this cohort. And therefore, keeping an eye on the ventricular function alone, not just doing pressures all the time, is very helpful. And so that's what they do in the pulmonary hypertension team. Other than EF and stroke volume, you can also look at CMR features of feature tracking. And this is more useful in patients who have biventricular circulations. And you can see that the circumferential strain rate here is actually altered in some of the groups. And that also then translates very nicely in this study to your long-term survival of where you use global longitudinal strain as the prognostic marker. How the heart works in relation to the circulation that it faces is probably best described by looking at this concept of ventricular arterial coupling. And effectively, you're looking at both RV failure as well as the downstream pressures. And that early adaptation is maladaptation, which goes into severe maladaptation. And you can actually use CMR by looking at the very simple relationship of the stroke volume over end systolic volume. I won't go into a lot of detail, but I left this reference up there for those of you who want to look at it. But that very simple relationship gives you an estimate of the ventricular arterial coupling, and you can see how it prognosticates patients very nicely. And that separates out even more when you look at patients with severe PH. And again, here you can see how that measured up very nicely when you then compare it to invasive measures of ventricular arterial coupling. So it's actually a pretty good marker in patients with a biventricular circulation. This is not really tested in patients with single ventricles, I have to say. And then you have to look at what happens to the ventricle, and we've talked a bit about the importance of tissue characterization, because as we know in that maladaptive process, you have increased fibrosis, which can then become replacement fibrosis, which you can actually see as late gadolinium enhancement. But obviously before that happens, you also get difference in your T1 values with interstitial fibrosis happening within the ventricle. In terms of flow dynamics, you can actually look at 4D flow parameters for those of you who have those sequences on your scanner. And you can actually look at vorticity and helicity, which gives you a marker of disruption in the blood flow. And actually this slide here looks a little bit fussy, but effectively what you're seeing is that comparing patients with pulmonary hypertension compared to controls in blue, you can see that there is definitely a difference in the indices of helicity and vorticity in the patients with pulmonary hypertension. And if you think about it, you know, on those black blood images to the right in a different study altogether, it makes sense because the PH patients, they have so much more distortion of the normal blood flow that on your normal black blood images, you can see that the spins haven't lost their signal because they're still hanging around, and you can see that that elimination of the negative contrast is not there, and that coincides with what you're seeing on the more fancy 4D flow images. So it's nice to see that the theory matches up to practice. You can also look at ventricular energetics when you actually fill the heart with blood. An efficient heart shouldn't have too much blood hanging around. And so what they looked at in this group is patients, if you look at the direct flow, which is a marker of energy efficiency, you can see on the right-hand side. In the green on the pie chart above is patients with pulmonary arterial hypertension. And look at the slides of that green wedge in the patients with controls. The controls have much more direct flow. And in the same way, you see that reflected in the left and right ventricle. So we know that the ventricular function informs the ventricular energetics, and that's determined by the degree of pulmonary hypertension. I think I would like to sort of catch up with a bit of time, so I'm going to just run through these slides to say that you can use large data and look at different means of shape characteristics in large populations of patients to help you risk stratify. So I think there will come a time where we'll put our patient data in from large data sets, and will help us in an incremental way risk stratify our patients. And some of that can be done in a semi-automated way to help you pick out the ones that you may have missed. I'm not saying that this is going to replace the human, because actually I'm always wary of screening tools where we say machine learning is going to help us. But if you look at the area under the curve, an area under the curve of 0.86 is really not good enough for a screening tool. You're really going to miss a lot. And what's useful is that we're seeing more CMR features as endpoints in the big studies that are coming through. So people are understanding that CMR is good in this patient cohort. And therefore, I think as the newer guidelines come through and the expertise increases, like Sophie said before, through a spirit of sharing and collaboration, we can get a lot more people experience in using these techniques so that the patients benefit for the best. So multiparametric tests without anesthesia, acceptable to patients to really improve patient outcomes.
I think that was the presentation from Dr. Pushparajah.
Mm-hmm. I think I have to present you, Dr. a famous Greek